Thank you for the introduction, and I would like to thank Dr. Prashant because we are integrated for doing tissue samplings. He's doing other way and I am doing other way. So we are closely related in that. I'm just discussing about few features. So the topic was given me as a PET CT and CT chest features, but I will say otherwise it is CT and PET CT features and want to chase the malignancy. So there could be various presentations. So sometimes we have simple solitary pyramid nodules. There can be consolidation, there can be mass-like features, and there can be significant destruction. And some of them are having very specific features, which we can think about that is directly dealing to the malignancy. And there are some features in which we are not very sure whether we are dealing with a malignancy or not, especially when it is a ground glass density nodule or nodules which are smaller in size. That led to the thing is that we have to follow certain guidelines regarding like that. If we have picked up the nodules which are incidental, we have to follow the Flushner Society guidelines. Earlier, these guidelines were given in 2005 for the solid nodules, which usually depended on the thicker slices. And then in 2013, they came up the subsolid criteria. And then in 2017, they revised the guidelines and they started saying about that we have to look for the thinner slice CT scans to categorize these nodules. And they have given a follow-up period, and usually that is a recommended follow-up interval period. So there has been greater discretion to accommodate the risk features apart from the radiology, and that will make whether the nodule that looks like on radiology, whether it's high risk or low risk. So it is only for newly detected nodules and people who are having a malignancy known or less than 35 years, we are excluded from the study. And usually to say whether it is a growing nodule or not, 2 follow-up examinations are sufficient to exclude the growth. And usually the period is 12 to 18 months when we are doing on the CT scan. And earlier it was 2 years when we are relying on the thicker CT scans and chest radiographs. So that is the thing. So the main part of the talk is there. When we see a nodule, what are the things we are going to see? We are going to see the morphology of the nodules and the size of the nodule and where the nodule is actually located, whether it is having a multiplicity or the nodule is growing over or not. And there are any comorbid features like emphysema, fibrosis, familial history, and other things. So there is a very nice article that has been given about the pretext probability that is dealing with the probability of any nodules that is going to be malignant or not. So the main important thing that is given is the whether there is a history of smoking, whether there is any history of cancer, and what is the morphology of the nodule. So any speculations and nobulations, the positive predictive value going to be a malignant nodule is very high. So it is around 80 to 95% the nodules, if it looks like to be speculated or lobulated, it is going to be very highly malignant. So the CT recommendations are that when we are trying to analyzing any nodule, we should have a thinner slice. So that is the thing that we can miss or we can overjudge or we can underestimate the potential of a nodule, whether it is a benign or it is malignant. So the thing is that the same nodule, if we see it is looking like a nodule, but if we do a coronary reconstruction, it is a lymphoid tissue that is sitting over the fissure. Similarly, the nodule on the lung window, it is looking like a speculated one. But when we do a mediastinal window setting, it is a fully calcified nodule. So this is how the interpretation of multiplanar reconstruction and different window settings can help to stratify the nodules, because volume averaging takes a toll. So the nodules which are purely solid on thinner sections might look like a ground glass nodules or a semi-solid nodules, and then that can give a false interpretations. So there are different techniques how you can measure a nodule. And usually we take the long axis and short axis and then try to draw the averaging of that. And one has to review the previous imaging that is available to us. Usually the criterias are size dependent, but majority it is like more than 8 or less than 8. If it is less than 8, usually the follow-up is done. And if it is more than 8, depending upon the risk stratification, we can try to see whether we have to do any PET CT or directly we can go for a tissue sampling. So something like nodules like this, if there is a probability of low risk, then these can be taken care of. But if there is a probability, these by other means and the criteria, if it is a speculated and lobulated and having a history of smoking and other features and it's looking malignant, then we can target these nodules. In this particular case, it was targeted because the patient was willing because it is unchanged over the some time, and that is the region for the target. So very small nodules, if we do sampling also, the sampling can be inadequate sometimes and can lead to false negative results. More than 8, usually it is a PET CT or a tissue sampling, but PET CT is rarely indicated in our center and our scenario because mostly if we see a risk stratification which is very high, then it will undergo direct tissue sampling without doing a PET scan. And if it is positive and if it is curable or radically treatable, then we do a PET CT for staging. So this is the nodule in which we can see that it's a very large nodules, but having a calcification, and then there are some fatty areas, though it is looking like benign, but by the guidelines, it will look like we can do a tissue sampling, but it was stable over the 2 years in this particular scenario. Something like this is really worrisome. It is having a calcification, but the moment we look at the windows, it is typically speculated nodules, and these are very high risk. On these bones are having significant osteoporotic changes, as well as there are some osteolytic lesions which are raising again the further alarm that this particular nodule can be malignant. It is turned out to be squamous cell CA on the tissue sampling. Something like this, again, having a speculations. These kind of speculations are very, very classical for adeno CA that we are going to see, and this is again on tissue sampling, it's proven to be adeno CA. So something having a speculations, corona radiata, or the sun rays that is appearing from a nodule, it's a very high risk nodule. Again, having emphysematous changes in this particular patient, and this is also be a high risk nodules having speculations around these nodules. But again, multiple solid nodules usually which are less than 8 millimeter usually can be followed up, and most of the time they are going to be benign. Something which is more than 8, one has to identify whether there is any dominant nodule is there or not. And if we can identify a dominant nodule and other nodules, then probably one of the nodules is primary and other is going to be secondary metastasis from that area. So in this particular case, there is one dominant nodule which is showing speculations, and these speculations, when the nodule is targeted, it is turned out to be adenocarcinoma. So there are additional considerations when we think of see about the nodules, that whether there is any apical scarring is there or not in that particular area, or how is the apical scarring look like, whether it is having elongated shape, concave margins, or straight margins. So these can sometimes be confused with the high risk nodules. We have to see about the perifacial nodules, which are usually 80 to 90% of them are going to be benign. And incidentally detected nodules should not be documented by the Fleshner if they are incomplete, having a chest CT scans. Either the scan is covered in a neck, which is half, or either the lower chest is covered in a abdominal scan. So one has to do a full scan and then do the risk stratifications. So usually we think about, there are a lot of these society guidelines are adapted into the lung cancer screening, and various guidance has been devised like ACR lung rates, Vancouver risk calculator, and Korean lung cancer screening project, which is usually taken care when we are talking about lung rates in a endemic country like India, things like that. And the thing is that because there is no specific criteria that has been followed up, and how the CT should be done, how the lung nodule to be identification, how the structure reporting to be done, the concept of lung screening is not taking off because of these issues. And radiologist has to educate people regarding the healthcare providers, how one should do a CT scan, a proper CT scan, to look for the high risk features in these nodules, because if the scan is not proper, it can be significantly skew the risk stratifications. So just to think about that, these features when taken into the ACR lung rates, if we are not having a specifically fully evaluated chest scan, the category is assigned as a 0, and it has to be further reviewed with a complete CT scan, an additional CT screening test. Something which is having a very calcification, either having a popcorn calcification or either having a fat, is a typically benign nodules with the risk of malignancy is less than 1%. Something which is like peripheral fissural nodules or subpleural nodules, If there is no history of lung cancer, then these are again considered to be almost completely benign. And we have to observe the temporal growth of these nodules. Something which is a part solid nodules is a starting feature of worrisome nature, and then these has to be followed up. Again, going to the speculated lesions, if we see any speculated lesion, these are actually a very highly suspicious category of the nodules. And then if we see some other features like emphysema or some coronary artery calcifications, we can add into these modifiers, and though they may not change the risk stratification, but they will talk about the comorbidity of the patients when they are actually surgically dealing with that. So in this particular patients, this is a known case of tuberculosis. And if we see a nodule which is having a lot of speculations into the right upper lobe, it's very highly suspicious by all other criteria for a lung malignancy. And we can see that there is a lot of findings of pleural thickening, fibrothorax, and other things, subpleural emphysema. And this nodule, when targeted, it turned out to be an adenocarcinoma with N0 and M0 status. So things where we need the PET scan. PET scan in our scenario is like 2 to 3% just to target the lesion rather than for a risk stratification, because PET CT can show avidity in tuberculosis, inflammatory lesions, and malignancy. And sometimes in mucinous adenoCA, it doesn't show any avidity. So the areas where we will need like a central lesion which is having a collapse component, probably when we want to target that particular area, we need the PET scan. Things like if there is a cavitatory nodule and any solid nodules is showing some avidity in that particular area. And things like that, when there are multiple pleural nodules and which nodules can give us a higher yield than in that particular area, we will need the PET scan. So PET scan is essentially in our setup is when we have a negative biopsy and to target that particular area, we will do. In this particular case, the lower lobe nodule was not showing any avidity when targeted. That's why PET scan done, and a nodule which is having a higher avidity is targeted. And then it turned out to be adenocarcinoma with metastatic disease. So just to confirm, we try to do the tissue sampling under CT guidance, and Dr. Prashant will do under EBUS setting. And both the goals are to take the tissue out of the thing. So the take-home points are that we should have thinner slice CT scanners for baseline evaluation, and look for the inclusion-exclusion criteria before stratifying any nodules to be a high risk, and do the risk assessment properly. And part solid nodules are more dangerous because these requires a longer follow-up period till 5 years. So we have to stick to the consistent guidelines, and we have to follow the principle of multidisciplinary group. And we have to do risk stratification. In our setup, we try to give more weightage to the radiological findings, and because it can standardize the management decisions, and we should involve other peoples like primary care physicians, radiologists, intervention radiologists, pulmonologists to better classify these nodules, because most of these guidelines are from a large targeted populations and still remain clinically relevant. So especially if the nodule is less than 8 millimeter and there are no other features, non-invasive follow-up can be done. But if it is more than 8 millimeter, tissue sampling is usually the answer. So thank you so much.
Thank you very much. We'll go ahead with the next one.
So next speaker is Dr. Santakumar, is a consultant pulmonologist, Courtyard Medical Center and Hospital, Coimbatore. So welcome, Dr. Santakumar.